Hi, everybody. Thanks for coming. I'm Keegan Checkett. This is Linda Rimpel. We are two of the 4 leadership team from University Hospital of Mirabelais. We want to take the opportunity here at SAM to tell you a little bit about our curriculum and what we've learned about residency training.
Good morning.
Morning.
Low-income countries, we have a disproportionate of burden of acute illness and injury. So people get hurt, get sick so severely, so I can say frequently. And unfortunately, in those countries, we have a limited resource setting. So for that, those people cannot get care everywhere all the time when they need. And as we can say, in countries where there is accessible, timely staff trained, we have a significant reduced of morbidity and mortality. So we think that should be the same for all other countries, even Haiti. So we think, as WHO said in 2007, that we should prioritize emergency development in all countries. For that, Health Ministry and PIH, ZL in Haiti, they received that call and start thinking about that. In May 2013, they opened University Hospital of Niamey. And 1 month after, they decided to open the emergency department. And in that emergency department, they were trying to have everything set up. So in September 2014, we finally opened our first emergency medicine residency program in Haiti. What was the state of emergency care in Haiti before that? In Haiti, we have different health structure, a reduced number of hospitals. And in those hospitals, unfortunately, they are under-equipped by materials, by supplies. And the staff, it's under-equipped too, because they are staffed by general physician and sometimes social resident in services. So it's a little bit complicated because they don't have enough training in emergency care to take care of those people when they are coming. And as you should know, a true emergency system should have 3 things. Accessible, because the patient can get it relatively easily and appropriate staff are present and working 24/7. It should be timely. Patients should get triage and being seen appropriately. And to be seen appropriately, we should have a staff trained. So a really staff trained in emergency care or to take care of patients when they are in emergency. That's why we think emergency medicine residency program, developing emergency care in Haiti is more than a priority for us. So it's really, really important for us to have emergency care, to have emergency physician, and implementing, developing care in Haiti. Still, we have our challenges. Here we are in our ED in Mirabelais, emergency department in University Hospital of Mirabelais. As we can say, in Mirabelais we have 21 beds. And 14 chairs. But most of the time, we end up to 30, sometimes 35 chairs. And sometimes patients spend nights on chairs because most of the time we are overcrowding. And delay in admission, a lot of other things that can happen causing that overcrowding. Other challenges that we have, patients didn't really understand emergency care. For them, they don't have time, so they need to be seen quickly. They come in emergency department. Even the staff, they did not really understand emergency care. And as we know, emergency medicine residency program, It's new in Haiti. So other physicians, as internal medicine, ped, or surgery, they didn't really understand what we are doing in emergency department, what we are doing as emergency physician. So that's what we are facing in Haiti, in Niamey right now. Then we are training a lot of emergency physicians. They need to get ready to facing those challenges. And for that, we have a curriculum. This curriculum is about 18-month didactic core. It's unique to HUM, meet all international standards. And now we are in process for a CGME accreditation, a CGMI accreditation. After this curriculum, and after 3 years with this curriculum, and after 3 years of training of the staff, I think that they should be ready to play their roles and responsibilities as urgentistes. As it, they will have to work clinically, advocate for AD emergency medicine nationally, work with other specialties to make them understand what is emergency medicine, work with the community because it's new for them, and you can understand that only Niamey is training emergency physician right now. So it's not for tomorrow to have all the country covered by emergency physician. So they need not only to advocate for emergency care training in all other structures, but working with all other university hospitals to make sure that they can open other emergency medicine program so we can cover all the country. Maybe in 10 years, we can cover all the country with emergency physician. And also, represent and advocate for Haiti emergency medicine internationally.
So the role for emergency medicine residency training and emergency care development is to train the future leaders for the emergency care movement in that country. We have a curriculum in Haiti. 4-year classes in, it's good, and it's working. And the reason it's working is because from the very beginning, sorry, my mic is making too much noise. And the reason it's working is because from the very beginning, we've crafted this curriculum with the future challenges and unique training needs of our residents in mind. As Linda said, they have to be really great clinicians. 1, if they're going to work in a limited resource setting. 2, if they're going to teach others. And 3, if they're going to garner respect from other specialties, medicine, peds, surgery. Like we all know as emergency physicians what that's like when the services upstairs are like, what is going on down there? But what speaks volumes is if we're dedicated and we're demonstrably skilled. A significant percentage of their careers are going to be spent training the pre-hospital providers, nurses, GPs, auxiliaries, and the bulk of the medical staff who provide the care in Haiti. And so they have to be adept both at creating curricula and teaching. And then advocacy and leadership are critical. So I can talk about each of these bits of the curriculum for 20 minutes each probably. We're going to try and hit the high points here, and we're happy to talk in more detail afterwards. A lot of these things are not particularly unique to Haiti. Like everybody's got admin, everybody's got education, everybody's got critical care. What's unique to these is the way that they were crafted to really take full advantages of the setting, of the challenges faced, and prepare the residents, again, for their future lives and careers. Team leader starts as a second-year resident. Strongest second-year start earlier. Goes for third-year residents as well. It's not play tending. The team leader is the resident who on shift is kind of captain of the ship. This is the person who's in charge of the board, keeps tabs on all the residents, particularly the juniors, doles out lunch hours, talks to other services and helps facilitate consults and admission, and just kind of, it's much more admin ops, helps keep things going. This resident is still carrying a full clinical load, but starts to introduce them earlier to a bigger view of what you need to do as an attending to run a unit. Our 3 nights are similar in practice to the way a lot of medicine residents learn critical care. You've got a couple, you're a senior resident, you've got a couple junior residents with you overnight. It's quieted down a little bit. Your fellow's asleep in a call room and can be obtained in an emergency, and you have an attending who you can call and wake up. But for the most part, you're kind of on your own with a lot of support built in, but you're on your own. And so that helps foster independence and decision-making skills. For our R3s, we do that by having one of the attendings physically present, so they're across the street, 10 yards away, sleeping in the call room, and can come in event of emergency, like cardiac tamponade or something. But they're online via WhatsApp and FaceTime on our iPad with one of the core faculty who might be in Haiti or might be back home in the States, like Chicago, who's attending that night to talk to the R3 and help staff patients and run through decisions. So it maximizes our faculty and takes advantage of the schedules that we all have and frequent travel and being all over, while building independence in our R3s. Sending them out to the community is really important for 2 reasons. It gets them used to the more limited environments. HUM is the highest level of care available in the public sector. It also kind of spreads the word of emergency medicine. And hospitals, community hospitals, get to see them in practice and see what good emergency care can offer. It helps drive energy behind the movement for emergency care. It also helps get them a lot of job offers. TCC is the teaching and critical care resident. This is the person who takes ownership of every critical care patient, not the primary resident, but works with the resident who has that patient, makes sure all the details are in place, and liaises directly with the ICU. This is important because there's really only about 2 or 3 ICUs in the country. So the vast majority of critical care is going to go on in the ER, and so we have to teach ER-style critical care. And then look it up. As with a lot of specialties and a lot of places in the world, the idea of a consummate physician, someone who's fully trained, is someone who knows all the answers, right? And to look it up almost, it's a little bit weak. And for us in emergency medicine, that's not practical. And if you're a young attending working by yourself at a peripheral site immediately after graduation, that's just scary. And so both encouraging looking it up and teaching this concept that looking it up is not only not weakness, but the clinically responsible and ethical thing to do. And then second, giving these folks the skills so that they know where to go for the resources, how to look it up, how to find the right answer quickly and efficiently in event of emergency. Finally, it's really nice because it links our EM residents in with the wider global world of emergency medicine, because a lot of the information is on foam, right? And so suddenly you have colleagues and support all around the world and lots of other folks who are in a similar situation. Davu is my favorite time of year. It is October, November, December. It's a little bit crazy and a lot of awesome. And the way it works is the R1s who have never been exposed to emergency medicine before run through an immersion course. And that immersion course is taught by the R2s and R3s with direct faculty support, but taught by the R2s and R3s. The R2s and R3s, as they're teaching it, run through a residence as clinician educators course. How to be good teachers, how to do simulation, how to write curricula, how to implement it. And then they practice teaching Davu. And so by the end of it, 1, the 18 residents are really tight. 2, the R1s are firmly urgentis. And 3, by the time they graduate, the R3s are now graduates, have a certificate course under their belt. Because the nice thing about CLE Davu is though we use it as the introduction to emergency medicine for the first years, it can actually be run by itself as a standalone certificate course. And so they leave residency with a teaching tool in hand. Pre-hospital care in Haiti, no formal 911 system exists. There's several private ambulance companies. So the residents who are going to be in charge of pre-hospital care and be the ones to develop these systems rotate with each private ambulance company, including the air ambulance company, to kind of make connections, learn a little bit about what they do and how they do it. They also staff a mass casualty event, which provides them with an opportunity to employ their skills from the disaster and mass casualty module of the 18-month curriculum. And they do ride-alongs and teaching for the HUM ambulance drivers. All the residents have a research requirement. They start a course about halfway through their R1 year. It runs through the end of residency. It's 2 hours every Wednesday afternoon. They need to complete a QI project and a clinical research project in order to graduate. And that's valuable because particularly as the pioneers of emergency medicine, they need to be able to document the burden of disease and the impact of emergency care in order to garner increased funding, support, energy behind this movement. The annual symposium for emergency care in Haiti is every summer, and that's run by the HUM residents and faculty, but specifically targets hospital administrators and government officials in order to get the word out about emergency medicine and emergency care development plans that this group has. And then osmosis and passion. When we recruit residents, we are very clear with them about the expectations, that this residency will be hard and what their lives are going to look like. So that when the residents come in, they're really excited and they're clear-eyed about what their careers will be and why they're going to do it. And so you get a lot of passion. And then by having such a tight group with seniors and faculty who also live and breathe that 24/7, kind of spreads, right? And then you have community. Which brings us to wellness and sustainability, which has been my predominant concern from the beginning. And these guys are awesome. Having tight friends and a tight community goes a long way. It's really hard to come into work every day and have to swim upstream, right? That's daunting. But when you believe in something bigger and you see it happening and you have both local and global champions who are behind you and have your back and support you and keep coming down and keep helping, that helps further the cause. So, the state of emergency medicine in Haiti, 4 years in. So we're recruiting our 5th residency class in July. We currently have 18 residents and 4 full-time Haitian faculty in the HUM ER. Our residents go out to 3 other sites to help strengthen and develop emergency care at those sites. And in November, we'll become a pilot site for the new WHO BEC course that the team will then use to start implementing formal emergency care, starting with Zanmi La Santé. So, our hope for this motley crew is that we generate a specialty and have lives and jobs that they enjoy, carve out space, and maybe start emergency care for our country. Thanks for having us. And it looks like we have 5 minutes for questions, if there are any.
Thank you very much for a great presentation and your efforts. I have a question about how you're planning to provide future employment for these trainees in a new specialty in the country.
Not a problem. Do you want to answer that, future employment? If anything, we don't have enough residents. Everybody wants to hire them. And we try to be very protective, and it's much more like, no, 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 they stay with us. You're not allowed to have them yet. Let's get a couple more classes through. So at HUM, we'll probably in the end have 6 or 8 full-time faculty. We have a 10-year plan. The goal is at each of the 4 university sites in Haiti to have about 6 to 8 full-time EM faculty there. And then at the more peripheral hospitals to have emergency care trained GPs and nurses working with the EM trained specialists overseeing the EC training and implementation for the GPs. But the word is out on the street. There's a lot of hospitals who are like, that looks great. We should do that, and are tapping our folks to get started. So it's not an issue. Other questions?
Are you experiencing, are you concerned about brain drain?
No.
With your residency?
No, not at all. The residents, most of them have dual citizenship and go back and forth pretty freely. And as I said, when we interview folks for residency, it's really clear what we're after and what the purpose of this is. There's a lot easier ways if you're looking to go somewhere else to do that. And everyone in this residency is there because they feel very strongly that Haiti needs emergency care, and they want to be part of that.
And they're very engaged. For them, they are cheerleaders. They just start that new specialty. So it's for them to improve it and to make everyone know what we are doing as emergency physician. So they want to stay. They want to promote that specialty.
Thank you. Thank you. That was a very nice talk and very impressive. My question is, it's okay, I'm loud.
It's for the recording.
Oh, sorry. Maybe I missed it, but how are you liaisoning and integrating with the MSPP in terms of making this a public health, Ministry of Health aspect and moving forward and, rolling it out throughout the rest of the country?
University Hospital of Niamey, it's true that PIH is running that hospital, but it's a MSPP structure. So when we have to open that hospital, MSPP calls it and asks them to open it. And with MSPP, we open that residency program. It's not PIH somewhere and MSPP other way. They are together, working together.
Maybe talk about the process for getting the resident. Could you share with the group the process for getting the residency approved through the government?
To recruit residents for emergency medicine, we have to do it through MSPP. They are doing the process. What we are doing, we in ZL, we come, and after the exam, they have to success the exam with MSPP. And after, we come for the interview and choose who will come to Niamey. But not Niamey is choosing. MSPP is doing it, and after we come for interview with them.
So everything was set in detail before the residency started, as opposed to starting the residency and then worrying about ministry engagement. And it all works through the national kind of match, if you will.
Question along those lines about those physicians who have been practicing emergency medicine for years and the practice clause that was available for emergency physician development here in the United States. Has that been part of the discussion of generating faculty to be part of this establishing emergency medicine as a specialty in Haiti?
So there are several GPs that we know of who have been working at peripheral sites for years in receiving units, and we've discussed how best to bring them in. We've offered many of them the opportunity to do residency training, and most have deferred. But for faculty, for the residents, we need to have residency trained or fellowship trained, specialty trained emergency physicians. And so that's Dr. Rimpel, Dr. Edmond, and now several of the grads. Because a GP is someone who hasn't done residency. Does that make sense?
Understood that.
Oh.
But again, many of us started in emergency medicine in the practice clause in the United States
Absolutely.
and became specialists in emergency medicine
Absolutely.
through that route.
Absolutely.
Is that available to that GP or to that physician to earn that specialty recognition?
No. They can do residency or they can do fellowship, but a GP cannot be one of our attendings.
Just as a follow-up to that, you're mentioning GPs doing emergency care. Are there any residency-trained physicians from other specialties that are doing like an internal medicine-trained, similar to kind of the practice pattern we had in the States, that are practicing emergency care? And would they be included? I understand that if someone hasn't done any residency, it's tough to integrate them as an attending in your hospital. But does that other person exist in Haiti?
It does, and we have a family physician who works, 2 family physicians who work with us in the HUM ED, but they work alongside us, and direct teaching and supervision for the residents comes from EM trained specialists, but they are working alongside the team and are very much part of the team.
You mentioned the BEC course and the site being a pilot study for the WHA BEC course. Who is that course geared towards?
That course is very much geared towards mid-levels, like mid-level providers. So your nurses, to a certain point, there's a triage component, and so that's particularly helpful for like the auxiliaires who are helping. It's great for medical students as just an intro to emergency care type thinking. Sorry, go ahead.
Sorry, I
What's your
probably
next
should have
question?
clarified the question. So who will be administering the course? Are the residents going to be administering the course or the faculty?
Well, both.
Okay.
The HUM emergency medicine, well, actually, the Haitian emergency medicine physicians who are now at HUM and at some other hospitals will be certified trainers, and they will provide the training and oversee the development.
At the beginning, they will train some trainers. Those trainers, they will be responsible to do that training for everyone, everywhere.
And so the initial trainers will be the faculty and senior residents.
Senior residents. To answer his question is just, before you said if we have another physician in emergency department, as I said before, yes, because we just start with emergency physician. And before starting with doing emergency medicine residency program, we already had emergency department. So we should have people working on it. Before we had GP, general physician, and family physician. And until now, we do not have GPs again, but we still have family physician working in our emergency department.
And the family physicians who work in our emergency department take part in all the didactics, what am I saying, like training modules like Airway Week, Procedures Block, all of that, so that they have continuing education opportunities as well. Anything else?
No more question. Thank you to you all.
Thanks, guys.